I take this as an opportunity to discuss my own complications. It's not about the what literature says. So I'll be showing you what I have faced as a remote access or robotic thyroid surgeon, and let us see, whether any of you can relate to it, or I don't know whether any of you have, have done or have associated with remote access any form in any form. Only okay, two. Okay, two people. I think rest of them are not here, so still lunch is going on, I guess. So to classify minimally invasive as well as minimal access, I would put it as, because some of them the access wound is small, so they can be classified as minimal access, and some of them are remote access. So to classify it, we have two clear groups. That is, one is gasless method and the other one is the carbon dioxide or CO2 insufflated method. So this is how you would classify any remote access or minimal access thyroidectomies. So this can be robotic or it can be endoscopic. So both are acceptable and they are interchangeable in many ways. So you can, based on your situation, you can choose between the two as to how to do. Because I started as an endoscopic surgeon, and then when robotics came in, I went into robotics using the same ideas as minimally invasive what I used to do before. Now, this is what I started doing, and I started developing this independently because the most popular technique at that time was transaxillary technique, which was using Chung's retractor. So I had to seek for a method which was possible without using any retractors, because my institution wouldn't have invested another 10 lakhs or 15 lakhs for that. So this is how the technique developed. So we went on from basic Baba, which I used to do, to seeing what would be the best. So I did not know that robotic Baba existed. It was not very published also at that time. So in 2016 or something around that time, when I wanted to go and get into it, this is how we started off. So there are differences, of course. They do two hemithyroidectomies, and there are many differences which I have highlighted in my paper as well. And the technique is similar to the endoscopic Baba, bilateral breast approach, bilateral axilla incisions, and there is a assistant port which I have in Rabbit. Now I'll just show you a brief video so that you understand the complications afterwards. So that was the position of the patient. These are the port positions and the flap, the extent of the flap. It is and once that is done, we enter the midline, and it is just like open surgery once you do that much. So you get the gland out from the tracheoesophageal groove, you dissect the tracheoesophageal groove area, go for the superior thyroid pedicle. In this, we don't use any clips or any ligation. We basically use bipolar to take care of the vessels. So this is the inferior parathyroid area. You can see the gland here, and the superior parathyroid is here. You can see the recurrent nerve and the branches of the inferior thyroid artery. So individual branches which are getting into the artery are taken care. So that is the recurrent nerve. Recurrent nerve arborizing and entering the the cricothyroid membrane. So once that is done, opposite side, you can see the left side, left nerve, you can see there, and the left superior parathyroid, inferior is down, down with the nerve there. So that is the superior, and this is the superior pole pedicle taken down. You can see the gland is bagged and removed. So this is how we follow for every patient. So quickly going to the complications. This is how the most common complications of thyroidectomy look. This is the literature. So the two most common are the temporary hypocalcemia. Permanent hypocalcemia is about 3 to 6% is the world literature which I had pointed out or seen in the various literatures. I think somewhere between 1 to 6.6 is what is seen across. Airway obstruction because of hematoma and tracheomalacia is about 1%. Recurrent nerve injuries, though are dreaded, are very, very rare to happen, especially in the hands of people who do regular. It's very rare to happen. Wound infections are other. Now, I'll directly go to my data just to give you an overall picture of what I'm going to talk about. So, this is 108 cases from May 2018 to July 2024. So, if you see this, I would just show you some interesting things. Indian population is overweight. 40% of them are, in the obese group in this category also. So, something which is important to remember, and that is a problem for remote access or minimally invasive surgery. Now, comorbidities are not a problem for us, but the type of surgeries which happened were like nearly 80% of it was total thyroidectomy, because predominantly I practice for malignancies. I don't do benigns, and in fact I have difficulties in convincing myself that benign thyroids need surgery, benign thyroid nodule. So for that reason, most of the times I send them home. So how does the overall pattern look? This is how it looks. The the drain removal is similar to open. Second day, maximum 2 days is what we keep. Most of the patients are discharged on the second day of the surgery. We can do it on first day also, but generally it is day 2. And pathology wise, actually 50% of it is papillary. We do have about multinodular goiters in about 15, follicular adenomas 10%, and predominantly, if you see, it is neoplasia rather than anything else. Now, what are the? I'm now directly taking you to the common complication, unique complications of remote access surgery. Now, when I was going through literature, it is similar. See, what I am experiencing with what I do is almost similar to what the rest of the people who practice remote access are facing. But the access, the way we access is different, because most of the Koreans are doing retroauricular approach or a large transaxillary like Chung's way of doing it. So the way I do is slightly different, but their way of, their complications are almost similar. Now let us look at the basic thing about neck. One of the important structures in neck is the platysma when you are doing minimal access, because that is your barrier between the skin and the dissection plane. Just like when you are doing in neck dissections, mainly neck dissection, that's where you would come across, right? So, but what is important to remember is platysma is deficient in the center, and that matters when you have to raise a flap, especially in open thyroid, yes, but there it matters less because you are directly in control of it. But when you are doing a minimal access, you have to be aware of how to protect the flap. So what happens? So this is a case where, see, in fact, I am only raising the flap here, so I take the blame myself. But you can see there is an amount of fat tissue left over here. This fat should have gone up into the flap. So you can see the skin over here. Can you make out the way skin charts when you use cautery on top of it is very clear. This is dermis. So dermis started opening. So that's when I realized, no, I'm going wrong. So this is the fat which should have gone up. So what do we do to protect the skin? So generally, as a rule, today, my team, whenever they start raising flap or whenever I ask anybody or train anybody, the rule of the game is that the investing layer of the fascia of the neck has to be on the top. It should go to the roof. So with it, once you come from lateral to medial, because laterally over the sternocleidomastoid, the fascia is well defined. So once you bare sternocleidomastoid, you're protecting the entire skin flap. So that is your plane. So that has to be kept. In this case, the skin got thin. We had to really sacrifice that bit of the skin and had to, in fact, the skin scar got adherent to the deeper tissues, and our plastic surgeons had to release it also later on. So that's one of the things which we faced in this particular case. Other thing that we face when we do minimally invasive is the bleeding from intercostal perforators. So see this, team is raising, one of the team members is raising, see the fountain. So that is an first intercostal artery coming from the internal mammary. So this kind of a bleed, actually, see, people, when you're handling it day in and day out, it's possible. But first intercostal artery is one of the common intercostal arteries to get injured. Perforator, sorry, is very common artery to get injured. So you have to watch, and off-camera injuries have to be avoided. So, this hook is a very dangerous instrument. So when in any endoscopic procedure and in any robotic procedure, when you're using a hook, be aware when you're taking it back also you can injure. So that's one of the important things. So off-camera injuries, if they're unnoticed, you may have a huge hematoma before you realize. So that has to be kept in mind. Now, whenever I have presented in any forum, one of the common questions which I'm asked is, in a thyroidectomy or any of this minimally invasive, if there is a bleed in the post-operative period, what do you do? Actually, these are cases which I have collected. In fact, this is not a part of the entire data which I presented, because there when I show you later, it will show zero bleeding explorations, because this was a different group of thyroglossal cyst case, where thyroglossal malignancy was there, and we had to do a thyroidectomy and a thyroglossal cyst excision, cystimes robotically. So this is the thyroidectomy specimen, and once that is done, we are doing a thyroglossal cyst resection, that is cystimes procedure. So you can see the thyroglossal cyst over here, and it can be done quite nicely without any problem. In fact, you would think, how would you cut bone? We realized that many bones can be broken, many hyoid bone can be broken just with the cautery also. But harmonic is a good means to cut, harmonic scalpel. So it uses ultrasound, and ultrasound energy is a good way to cut, bone tissue. So we can do that, and we can get a beautiful clearance around. See, cutting muscles is not a problem robotically, and vision quality is good when you do, and you don't need to extend incision in any direction. You are going through the same incision, completing the resection from below, and getting the entire tissues down into the wound, and you can bag it, you can remove it very easily. So that is the suprahyoid area. You can see hyoid has been cut, and the hyoglossus muscle is being cut over there. So this case was done. Happily went home, and I was traveling probably. Next day there was patient looked like a bullfrog, huge hematoma. Now what did we do? In fact we just took the patient back inside, did an exploration endoscopically. We didn't have to dock the robo or anything. Explored, washed the entire area. This was a muscular bleed, not from any major vessels or anything. In fact, my teachers always told me that whenever there is a thyroid bleed, it is never or hardly ever a major artery. It's usually some vein, some small vein somewhere, or it's a flap. So that's how it was. So here also it was some muscular bleed, and we had to coagulate it. So other very common problems which we face are skin related. This looks very scary when you look at it. You start thinking that skin is necrosed, or we are going to have a full flap necrosis. These are just bruises. So some people are easily bruisable. So this is how you see, but these are not a factor which you should worry about. It resolves very easily, and within a week, patient is absolutely normal. So this is a breast hematoma also. Most of the times hematomas don't require any procedure; they resolve by themselves. Seroma is another thing. I think because the space which we create is very large. So especially obese patients or patients with diabetes, we have seen increased incidence of seroma formation, and some of them may require 2 or 3 aspirations before they settle down. Another very common question which I am asked is CO2 embolization. How do you encounter and emphysema? Actually, both these things I have never encountered till date. See, I know we might have done about nearly 200 thyroidectomies robotically till date, but my surface accessible organ surgeries, minimally invasive, is more than 2000, because I do inguinal block dissections, I do neck dissections, I do perforators robotically. So, and nowadays we have started doing breast also. So, till date, I have not encountered CO2 embolization or emphysema. But remember, there is a reason for that. Though there have been recorded incidences of CO2 embolization, the very nature of carbon dioxide, the physiology of carbon dioxide does not allow it to easily embolize, because the moment it enters bloodstream, it dissolves in the blood. It does not require RBCs to carry it. Carbon dioxide dissolves in the blood instantaneously. Only if that blood carbon dioxide in the plasma, if it is saturated, that's when it can embolize. Otherwise, it does not. So, what we generally do is we ask the anesthetist to look at the EtCO2 levels. So, generally what happens is when any vein opens up and carbon dioxide flows into the blood or gets absorbed through the raw tissue, EtCO2 starts rising. And typically, if embolization has to happen, the EtCO2 drops. That is what happens. Any anesthetist, I think, who's there? I think, sir, anesthetist, right? Yeah, so I think you would also be able to tell you, but the typical feature of an embolization is a drop in EtCO2. So here, the moment you see a rise in EtCO2, you need to act. The action would be either to take care of the culprit vessel, drop the pressure, because if you're not having any bleeding, you're seeing EtCO2 going up. You can stop your surgery, you can stop the insufflation and look at what is causing it. It could be the tube also. So other factors you can look at. But we always have a dictum, and we always tell the anesthetist that in this particular case, in superficial surgeries, if EtCO2 is rising, blame the surgeon. It is not the anesthetist, because they usually think it is the tube misplacement, but it is not. First thing to blame is the surgeon. Post-operative emphysemas are extremely rare with carbon dioxide. I have not seen it. But let us go back to that, again, physiology. Why does emphysema happen whenever we have trauma or anything? It is the nitrogen. It is nitrogen which causes it. So if your gas is contaminated, that's when you will have emphysema. So a medical grade carbon dioxide, the chances of emphysema are nearly nil. Unless you push in air by some mistake, this is not going to happen. Right? So this is my experience, and I stand by it after doing so many cases. Now, I showed you complications, and this is how our complication list looks. This is nearly 101 cases is what, actually 100 cases. The one extra is because of completion thyroidectomy for the same patient. Now, if you see this, hematomas, which I showed you, are two. Flap ecchymosis, sorry, 2 cases had hematoma, we didn't intervene there, sorry. Flap ecchymosis you saw, vocal cord paresis, breast hematoma, which I showed you, and buttonholing, which I showed you. This is how our complication list, other than parathyroid related complications, look. When we look at the factors, which really, this is a logistic regression on that. BMI is the factor which contributes, and the duration of surgery is other thing. So the two could be linked again, but with every 10 minutes of increase, we are seeing an increase in complication by 5% against statistics. Now, coming back to the complications, we have the temporary, I have to address the parathyroid related complications. So this is how we classified the parathyroid related or hypoparathyroidisms and calcium levels. So if you look at this, in our practice, in our hospital, as an algorithm, this is how we look at it: below 5, 5 to 10, and above 10. Now, above 10, we are practically safe. 5 to 10, we are worried about temporary hypocalcemias bothering us. But here also, in 11 we have C, but generally about 5 to 10 is where we see some temporary prolonged hypocalcemias. These ones will recover. The about 10 ones we have seen, they recover within 2 or 3 days, because they are basically we don't know the cause in many situations. So 15 is our cutoff for in the lab value, and below 5 is the worrisome group, because in this group nearly 25% end up with permanent hypocalcemia. That is what we are seeing, hypoparathyroidism. So this is the data which we are seeing. And when you look at the factors affecting hypoparathyroid status or permanent hypoparathyroid status, these are the things, permanent as well as temporary. So of course, I told you, low IPTH level is something which is a significant factor. But again, duration of surgery and intraoperative parathyroid gland identification are the 2 factors which really matter. Again, see this, it is a qualified kind of a thing. See, every additional parathyroid gland that you identify during your surgery, your rate of hypoparathyroidism goes down significantly. So this is a very important thing which we found. And also what we have realized, so also what we have realized is, this is the learning curve which we saw. Sorry, I have to point out to you, I think it's a very crowded slide, but as we went on doing, it's grouped into first 34, middle 33, and the last 34. If you look at this, our transient hypoparathyroidism, that is below 5 group, has significantly come down over the past, over these numbers. Like the last the third group had only 3 cases which had hypo. So, and this was a significant difference. And other groups are, anyway, they don't have any statistical significance as such. Also here, very important point is, temporary hypoparathyroidism also came down. And permanent, of course, is 0. But see, numbers are small. But then, when it is 100, you do have some statistical value which you can generate. We have only used chi-square test. So at present, in the last 34 cases, our hypo is very low. Permanent hypo is 0%. Now, we went on to look at what really made a difference. See, when you look at parathyroid gland, in the last about 50 cases or 30 cases or so, we started using indocyanine green to identify the gland. It's not about vascularity alone. We started looking at whether we can identify it convincingly with it or not. And if you look at this, in 30 cases which we used it, our identification rate was 100%. So that was the difference which we saw. And this was, in fact, this was also interesting for us because the technique, the way we do it, has been evolving over the years. So, and that I'll show you the technique also. But this is a good thing which we saw, that it is possible, especially when we are doing it in a good controlled environment. Now, these other things are very this one, but superior larynx is a recurrent nerve. I think as a regular thyroid surgeon, for a routine thyroidectomy, it's never an issue. We identify it well and preserve it. But for superior laryngeal nerve, very often we think we preserve, but it's a very tiny nerve. As of today, I can tell you that my you see, in the early 30 cases, I would look for it and identify in only 20% of the times. Today, whenever I do, it is 60%. This is what is my number. Now, how do we identify parathyroid? So this is how we do. I compress the gland, whether it's right or left. We compress. We give indocyanine green. So you can see the two glands shining up like this. What happens is, it's the first structure in the neck to light up when you give indocyanine green. There is a differential lighting up also, but the best way to do it is you compress the thyroid well, so the vascularity of thyroid gland is reduced. So only parathyroids will light up. Lymph nodes will take time because lymph nodes are not so vascular. So parathyroid is the first structure to light up once you compress the thyroid gland and give indocyanine green. So once you complete the surgery, you can do you can confirm the vascularity by doing angiography. It's the same case. You can see both the glands well lit up. Here it's little far, so you are not seeing it, but this is one and the other one is here. So this is slightly blackish, but the blood supply to it is reaching it. So generally we believe it will recover. Now, in cases where we cannot save, what do? We take it out and re-implant. So again, in this case, it was a very, very heavily loaded central compartment where we had to do a complete. There were nodes in this area, so we had to complete, or I had to take out this, send it for frozen section, and we confirmed, and we were discussing in the morning, mince it, and we are implanting it in this case, or in remote access, in the wound into the pectoralis major muscle, because you have an easy access over there. So we don't implant it anywhere else. We implant into our primary wound area. We implant it into that, and we place a clip, because here there are no other clips. So it's very easy to identify it for a future cost. And you will never enter in this area, right? So that is that. And yeah, so coming back to the literature search which I did, this is how it looks. Where do we stand today? Including the learning curve, that is first 30 cases, our complication rates today, total complication rates are about 32.67%. I feel if I exclude the first 30, it would look better, but I don't want to do it for the purpose of learning curve. Temporary hypo is 21% acceptable by the world standard. Permanent is about 2-3%. So this is how it looks. And the rest of the complications really, in practical sense, don't matter. They are not very morbid, or in fact, none of them are, and all of them, rest of them are clumped into one class group. So they are not very requiring any major intervention. Rest of the things here, if you look at ecchymosis and all, that does not matter. Only thing which really you need to look at is the operative time. When you compare to average operating time across minimal access platforms, it is around the same, around 200 minutes is what is being seen. But as you do, in fact, my time also has reduced over the years. Now, other thing which we would face is like this cases, like Dr. Prathamesh was talking about, scenarios where this is a case where we didn't expect it to be this bad. When I looked at it, intra-op, we realized that this is not a case where I want to proceed without opening. So, would you end up in a situation where you have to open? Yes, in bad cases, because in the interest of your quality of work, you need to open. This case, we had to open, resect a portion of that cartilage and complete the surgery. So, what other things? This is not because I go around training a lot of people. This is from one of the people whom I trained. So he shared this video after 2 weeks. So this is what was happening. She had undergone rabbit and delayed tracheal injury. So probably because of bipolar usage or whatever. But luckily, this patient didn't need any exploration or resurgery. It resolved in 2 weeks. So generally, as we see with many other tracheal injuries, they do resolve if you give adequate time, because even in tracheal resection, sometimes you can face this. So they resolve by themselves. But if it does not, you need to re-explore and put a patch, as it was being discussed earlier. So, can you handle difficult anatomies robotically? Yes, you can. In fact, this is one of the cases where I was looking desperately for recurrent nerve. No recurrent nerve in sight. In fact, I almost entered esophagus looking for recurrent nerve. Then I thought, this is non-recurrent. Went up. This is the nerve. It is entering I could spot it above. So it was possible to identify. And of course, you have to be cautious. The superior pole region is difficult when you do robotically because muscles come. It's okay to cut muscles if need be, but you have to be cautious and go stepwise. Even when you are doing any case, your surgical steps are very important. Do not miss them. Do not end up. See, if we had ligated this, thinking that it is a part of the superior pedicle, then patient would have had problems. So large glands are possible to do, but not in the beginning. So in the interest of not getting into complications, always restrict yourself to 4 centimeters in the beginning. But as you go on, it is possible to do very large glands. In fact, it's possible to do intrathoracic extensions also. This is a 20 centimeter, 15 centimeter, I think this scale is. So going into thorax, dumbbell shaped, cannot be addressed from the neck. We can't pull this up because it's dumbbell shaped. So you have to go into thorax, do the thoracic part, come up and do the neck. And many of these patients, when we do robotically, we have seen, I can send this patient on 3rd, 4th day, 5th day home. Pediatric cases also, bilateral neck dissections and thyroidectomy for papillary carcinoma. It is possible. Smaller build is a concern many times, but it is possible robotically. Thank you very much. I hope I have been able to do justice because of, I covered what is my experience rather than, trying to get the world experience. So I hope it was useful.
Thank you, sir, for covering all the nuances of minimal access spectrum of complications. We are open to questions.
Sandeep, you showed about your first 30 and then thereafter. How did you manage to avoid complications in the first 30? Because you moved in from open to endoscopic, and then you started off the journey. So if somebody has to duplicate that, what steps should be undergo?
See, for me, my greatest positive was endoscopic thyroidectomies, because for me, I was already used to minimally invasive, and I do head to toe, so that volume was there always. So I was comfortable with carbon dioxide. But I think to begin with, if you're straight away entering thyroid, then it is better to have a proctor and do it, because otherwise it's see here in this, what I see is, in rabbit technique, what I have realized is it is the access which is more important, because once you access the gland or access the space, then it is as good as open surgery. You just need to know how to use the equipment. Unlike retroauricular approach and all other approaches, the view here is same as open surgery. You won't find anything different. Anatomy is same. You don't have to learn the upside down anatomy of Totiva or any of those things. So I find that it's just learning that access which is more important. And I am seeing that for the people whom I have trained, they are picking it up within 5 to 6 surgeries. They are not taking this long. For me, it was because I had to, we had to see a lot of things like position. How do we position the arm? We started doing with taking the arm up and all those things. And over time, now it is down. It's we have that, I showed you that position, no? So that's what we use. So, and then we were initial few cases we did from left as well as right, based on the dominant nodule. Which side is the nodule? So let's do it from that side. Then after that we started realizing that it's not required. We can do everything from one side. Yesterday I did a medullary carcinoma thyroid, where I have done thyroidectomy, central compartment, bilateral neck dissection from the same side, single docking. Single docking. I didn't need to. I have done a complete comprehensive neck dissection bilaterally. Not heavily loaded with nodes. Lateral was okay. Central, there are a few nodes. I had some mediastinal nodes to address, which I went into thorax and did. So, but it was possible to do, and it was a very comprehensive dissection. So, so the thing is, initial first few cases we were very, very strict that we will not take anything more than 4 centimeters. So case selection was very particular, and that's how we went on. So. I think first, at least on 30 cases, I think the case selection will really, really matter. After that, I think you can really start doing other things. That's what I am seeing in what I have done, learning from my own series. But I think for others, it will be little shorter, because because this is already there. I can tell you what not to do.
Right. Sir, are you doing even the transoral?
No. It's I always quote Bruce Lee for that.
Yeah.
Yeah. I practice the same kick 10,000 times. I don't want to practice 1,000 kicks one time. That's the only way to see. You can transoral, though looks very attractive, because it looks very natural. There's no other scar. But at the end of the day, your access to both sides of the neck is not there, and you have to relearn the anatomy. So it may be excellent for central compartment, going there and doing a small nodule in the isthmus or some small nodules in the thyroid. But I think most of the people who do it, they always say that it's difficult to do lateral, like large glands and all that. I don't think they will be able to progress to a 10 centimeter gland. I don't think it's possible. I can do that for I have a lot of young people coming to me with large nodule. I'm comfortable today. Size does not matter there.
Sir, just one more thing. Regarding complications related to the shoulder and any sensory issues in the upper chest, can you please let us know how is your
right. Actually, see, in open surgery, the wound and the numbness coincides because you are lifting the flap, right? So the pain of the wound, the numbness of the flap coincides in the same spot. In this, the wound is somewhere else. There is a discordance. You have a wound somewhere else. There is numbness over the little lower than open surgery because it's in the near manubrium. because upper flap you're not going as high as open surgery. You will limit it. Most of the times you will not go, you may just reach if at all the thyroid notch, you will not go beyond that in any case. Even in large glands you will not go. So you stop there. So basically your numbness in this is actually around the manubrium, and generally the sensation comes back in most of them by 1 month they are almost, they get sensation in that area. Something which may remain will eventually become normal over time. It does not really, it's not permanent.
Sir, and one more thing, the case which you had shown regarding thyroclastic cyst. So, is there any issue if you go till the base of tongue, exercise the part, and then?
We can do it.
So, regarding the carbon dioxide leak.
See, if you are going up to base of tongue, only the last part, right? You would have finished the surgery, but we have not done in that entire tract you are talking about.
Yes.
Coring of the tract. But see, if you see the tract clearly, that's when you can really core it. Otherwise, what are you going to core, right? So if you see we can core it, it's not a problem. Up to skin, up to the mucosa, it's possible to core. But I have not had to, because we have done only about, I think, 4 or 5 cases. We are trying to publish that. I think Dr. Akira was trying to publish it. I think 5 or 6 cases. Guys are there. How many? 5 cases.
Even in open thyroid assessment procedure, after removal of the body of the eye, very rarely, I have done more than 10 cases. I have not done through the base tongue coring
Yes.
and removing the tract.
Yeah.
None of the patient have done so
Yeah.
far. But only important is the entire body of the iliac bone has to be removed.
Central body, yes.
I don't know whether coring, if you feel whether it's beneficial or not.
We don't do. I have also not had to, so that's why he asked me, can we do it? We can do it, but I have not done it. Because for us, the vision in this is from below. So, in fact, I am finding it very useful to go even beyond, like for example, parapharyngeal masses we are doing with robotic approach nowadays. Because even nasopharynx I can access parapharyngally through the infraclavicular approach. And patient doesn't have any external wound at all and no mandibulotomy, nothing. We are just going, we can entirely get the mass out. So, because it's from below. So the approach and the vision quality is very good. We can identify everything, preserve and do it. So that is something which, with robo, from infraclavicular, it is very beautiful.